Okay, so today we'll talk about the left to right shunts, and this is the diagnostic set where, remember, we always start with the pulmonary blood flow, and there's increased pulmonary blood flow. We ask the question if the patient is cyanotic or not, and these patients will not be cyanotic, so here you're in the category of left to right shunts. The most common I've listed for you here, so we'll talk about these. These are some of the less common. Coronary AV fistula we've covered before. There the problem is really ischemia, not so much the left to right shunt component. And here with ruptured sinus of valsalva aneurysm, there you will get a left to right shunt if it ruptures into right-sided chambers, but again the problem is the rupture itself and not so much the actual shunting. So for a lot of the defects through the atrial ventricular septum, it helps to understand a little bit of the embryology, and you've all had this where you have septum primum, ostium primum, septum secundum, ostium secundum, etc. And then the various defects explain where we have the communications and the holes. And so for the formation of the atrial septum, here's kind of a movie that shows you how that goes, and then by the time you're done, you have this potential communication, or in utero, it's an actual communication between the right atrium and the left atrium through the foramen ovale, pedal foramen ovale. And then if there are defects in here, then you can have an actual atrial septal defect. And so, of course, the most common of those is a secundum defect, which occurs right in the middle of the atrial septum. And then the endocardial cushions are also important because these will contribute to formation of defects here higher up within the ventricular septum and also here lower down within the atrial septum. And the most primitive of those, if you have a complete endocardial cushion defect, that's where you can have communication of all four chambers through the center of the heart. With these ventricular septal defects, we can have perimembranous defects, we can have muscular defects, and we'll talk about these in a little bit more detail. So starting with this case, what kind of view are we looking at here?
Three-chamber.
Yeah, so this is, so it's bright blood imaging, cardiac MR, it's a three-chamber view. Here we have the left atrium, the left ventricle, here's the aorta. So what is the problem? Do we see a problem here?
VSD with low aortic regurg.
So so we do see some aortic regurg, and then here you can see a ventricular septal defect there. What kind of defect do you think that is?
Membranous? No.
Yeah, that's through the thinnest portion of the ventricular septum. So that's a perimembranous or membranous VSD. So the four types of ventricular septal defects, for those of you that have done the reading, what are the four types? Yes, so membranous or perimembranous, right? What else? Muscular.
And outlet.
Right, those are the basic types of your ventricular septal defects. And so the ventricular septum has various portions here. There's the membranous portion here. There's the trabecular or the muscular portion here. There's an outlet portion, and then there's an inlet portion, which is near the inflow valves. The outlet portion, of course, is near the outflow valves. So for these ventricular septal defects, the perimembranous VSDs are the most common. Outlet VSDs can be divided into supracrystal or infracrystal. Inlet VSDs, these are usually associated with endocardial cushion defects, and then trabecular or muscular type VSDs. Sometimes these can be multiple VSDs in that location. So the opening on the right side here is a diagram showing you the opening on the right side and the openings on the left side of these various types of ventricular septal defects. So for the outlet ventricular septal defects, here on the right side is the Christus or the ventricularis here. They can be above or below that. And then here's the opening on the left side for those. And then you have your inlet VSDs near the inlet valves there. And then we have the inlet VSDs here. Number 3 are your inlet VSDs near your inlet valves. And number 2, your perimembranous ventricular septal defects. And then number 4, your muscular trabecular types of ventricular septal defects. So with the higher ventricular septal defects, and as illustrated here on the angiography, this can sometimes show a pacification of pulmonary arteries in the right ventricular outflow tract very early after injection because the defect is located so high. So the contrast just goes shooting right into the pulmonary artery there for those types of ventricular septal defects. There is a valvular problem that can occur secondary to those high supracrystal ventricular septal defects. What kind of valvular problem might be associated with those? Well, what valve are they near, right? They're near the aortic valve, so aortic regurgitation. So the supracrystal ventricular septal defects most strongly associated with aortic regurgitation, and they can lead to a sinus of Valsalva aneurysm from prolapse of the sinus of Valsalva into the defect. There's good news, bad news. The good news is it can help to close the defect. The bad news is you can develop aortic regurgitation and a sinus of Valsalva aneurysm from that. Okay? And then here's an example here. We have prolapse of the sinus of Valsalva into a ventricular septal defect. You can actually see the aortic regurgitation here coming down into the right ventricle. So these membranous types of ventricular septal defects, these are the most common. They may be very small. They may tend sometimes, or in many cases, they close spontaneously, and then sometimes you can have multiple ventricular septal defects, especially through the muscular portion of the interventricular septum. So these VSDs, they can be small, they can be large, and you can think of it as compared to the area of the aortic annulus, small if it's less, large if it's greater. That's called a non-restrictive VSD if it's very large. And that actually results in equalization of pressures between the right and the left ventricle. So if you have a very large VSD and you have equalization of pressures between both ventricles, why is there a left to right shunt? Why is there increased pulmonary blood flow? Because of what?
Higher pressures in the aorta.
No, the pressures in the ventricle are the same, right? So you're not going to see out there the pressures in the ventricles are going to be the same there. But you're kind of on the right track. It's not so much the higher pressure in the aorta as much as it is the lower resistance in the pulmonary vasculature, right? So the lower pressure in the pulmonary arteries, so the lower resistance in the pulmonary vasculature. So the blood follows the path of least resistance. So that's why you tend to get left to right shunting. You get more pulmonary blood flow than you have systemic blood flow in those cases. So the volume of the left to right shunt is determined by the size of the ventricular septal defect and the pulmonary vascular resistance. If you have low resistance, you'll have a larger shunt. With these large shunts, patients eventually develop pulmonary artery hypertension, and that increases the resistance, and that can also start to decrease the amount of shunts. Small VSDs do not produce radiographic findings. We don't see findings on the chest radiograph until we have larger VSDs with more than a 2-to-1 shunt. So if you can actually see the increased pulmonary blood flow on the chest radiograph, then that implies that you do have a significant amount of shunting. So VSDs are the most common congenital heart disease in children. Bacterial endocarditis can be a complication, and most small perimembranous and trabecular VSDs will close spontaneously, 75% by the age of 10. When infants are first born, they have high pulmonary vascular resistance. So with any of these lesions where you can have increased pulmonary blood flow, that may not be apparent clinically or even on the chest radiograph or even clinically when the baby is first born. So what happens is because of high vascular resistance, you don't actually see the left to right shunting. It really doesn't manifest until the vascular resistance starts to drop, the pulmonary vascular resistance. And when that drops during the first few weeks, then you can actually start to see the increased pulmonary blood flow on the chest radiograph, and also clinically, then the shunt becomes more apparent. So small ventricular septal defects will not produce any abnormalities on the chest radiograph. Again, you need at least a 2-to-1 shunt before we actually see it. Now, when you do have radiographic findings, right, from these lesions, of course, we always start with the pulmonary vascularity, so we'll have increased pulmonary vascularity. As far as chamber enlargement, the chambers that are enlarged with ventricular septal defect are
Left atrium, right atrium, right vent.
biventricular enlargement, so you'll get biventricular enlargement and you will get enlargement of the left atrium. Okay, and then you can see that over here, and some encroachment here also on that, from the right side of the enlargement. But the left atrium will enlarge with the VSD, right? So we'll have biventricular enlargement and we will have left atrium enlargement with the ventricular septal defect. The large ones can result in Eisenmengers, where the pulmonary pressures and the vascular resistance get so high that it actually starts to convert a left to right shunt into a bidirectional or a right to left shunt. And if it's predominantly right to left, those patients can actually develop cyanosis at that point. With larger VSDs, you'll expect to see much more pulmonary vascular resistance, much larger pulmonary vessels there, and also more engorgement of the pulmonary vessels. So the degree of cardiomegaly proportional to the amount of overcirculation. If there's decrease in pulmonary overcirculation and cardiomegaly, that could be good news, bad news. It's good news if it's because there's been spontaneous closure. It's bad news if that's the result of increasing pulmonary artery pressures and the development of Eisenmenger. And so if the pulmonary vascular resistance is very high, right, then actually closure with VSD is contraindicated. Why?
Ventricular dependence.
Yeah, the flow within the pulmonary circulation becomes dependent then on the left ventricle, and the right ventricle can't handle it. So the right ventricle would fail because of the high resistance through the pulmonary vasculature. So here's an illustration of a patient who actually has developed Eisenmengers here. How do we know this patient has Eisenmengers?
The filling of the aorta.
So what chambers inject?
Right ventricle.
Yeah, the right ventricle, and what happens?
Right to left shunt.
Yeah, you can actually see contrast going across the ventricular septal defect and, big pulmonary artery, of course, but you can actually see the contrast going into the aorta. All right, so there is right to left shunting here. All right, so this is a patient with Eisenmengers as a result of their ventricular septal defect. Okay, so for these three types of VSDs, what type is each? Well, it's high in the ventricular septum, B, yeah, C, yeah. So supercritical, so C is an outflow type. Near the membrane, that's a membranous or perimembranous ventricular septal defect. That's a muscular defect. This is very high, so that's a supercritical defect. It can be hard sometimes to differentiate those from the perimembranous ones, so you really need to look at all of the views. Right? So here again, we have a pretty high ventricular septal defect there. In that case, outlet defects are very high there. And then you can actually see the rotation of the sinus of Valsalva there as a complication of that. And what kind of VSD is this? You can actually see on the bright blood imaging, that turbulent flow here going in from the left ventricle into the right ventricle. So this part is what part of the ventricular septum? Yeah, it's the membranous, right? That's the very thin portion. So that's a membranous ventricular septal defect. Okay? Those tend to be the most common. What's going on here? We can all see the defect, right? It's very large.
Communication of all the ventricles.
So what kind of defect is this going to be as far as for the ventricular septum? What do we call this?
Atrioventricular defect?
Well, it has to do with the endocardial cushions. It's an inlet defect, right? For the ventricular septum. So it's an inlet ventricular septal defect for that. Okay. All right, so this view is, that's the easy part. What kind of view is this? Three chamber, right? Here we have four chamber. And then here's kind of a, yeah, it's an outflow view, outward view there. So what's peculiar looking here?
Big right ventricle.
What's going on? What do you see that's peculiar? Well, is there a VSD? Do you actually see shunting going across?
No, it's more like the membranous cartilage.
Yeah, so here, so you see the membranous portion of the ventricular septal, of the ventricular septum here is really bulging, right, into the right ventricle. See that? So what is that? What do we call that? And what's the implication of it? What does this mean? What is that? Well, first, what's it called? Yeah, so-
Aneurysm.
Well, it's not a sinus of valsalva aneurysm. The sinus of valsalva is up higher, right? This is the ventricular, this is the membranous portion of the septum. So it's an aneurysm. It's a ventricular septal aneurysm, okay? But how does that form? How does this occur? No, it's not an infarct. This marks the site of a closure of a ventricular septal defect. So when these membranous VSDs can close, you can be left with this ventricular septal aneurysm, that bulging there across the membranous portion of the ventricular septum. Okay? So that's a ventricular septal aneurysm. Usually marks the site of a closed ventricular, membranous ventricular septal defect. So, as we said, most isolated trabecular and perimembranous VSDs close spontaneously. Ventricular septal aneurysm. This might contain a portion of the leaflet of the tricuspid valve, which contributes to the aneurysm formation and to the closure of the ventricular septal defect in the location. So, if you see that, that's what it means. Okay? Now, if we're doing MR and we identify that the patient has a VSD, and we want to know, we want to, of course, quantify it, how much of left to right shunting is there, how do we do that?
Is contrast,
And so where do you take your measurements?
aorta, pulmonary artery.
Yeah, so you take your measurements in the ascending aorta and the pulmonary artery, and you compare the blood flow. How much blood is going through each, right? So you want to make sure you're perpendicular to the vessel, so you orient yourself perpendicular vessel, and then you take your phase contrast measurements in the pulmonary artery and the aorta, and now they should normally be the same, right? You should have the same amount of blood going through each, so what do you expect to find if you have a VSD? Yeah, you will have more in the pulmonary artery. So when you compare the flows, these should be about the same. But if you have a ventricular septal defect, you can quantify the QPQS. Right? You'll have more flow in the pulmonary artery and the aorta. You can actually measure that, quantify that, and that gives you an idea of how much of a left to right shunt there is. So we can do that with MRI. Okay. What do we have here on the left? What kind of views? Yeah, these are four-chamber views. What sequence? Yeah, these are dark blood. Usually these are done with what we covered the pulse sequence here. What's the pulse sequence? Double inversion recovery fast spin echo, right? Here you have your bright blood imaging, right? So first, look at chambers. What chambers seem to be enlarged here? What's that? Right atrium, what else? Right ventricle, yeah, right ventricle also. What do you think of the thickness of the right ventricle here? Yeah, it's a little bit of hypertrophy there. So what's the problem? What's going on in this patient? Yes, you can see that there's an atrial septal defect here, right? So here's a patient with an atrial septal defect, right? So the most common the type of atrial septal defect that is most common is secunda, right? That's the most common. Now, what are the other types? What are the different types of atrial septal defects? What can we have? What's that? So we can have sinus venosus ASD, You can have secundum ASD, and you can have prima, right, prima atrial septal defect, right? Those can be associated with endocardial cushion defects. And there's some other types too. There's an inferior sinus venosus that can occur here, down here, near the insertion of the IVC, so that can also occur. Okay. So secundum, through the middle of the atrial septum, is the most common type. Your ostium primum ASDs, they occur down here along the inferior part, along the inferior part of the septum down there. They can be associated with endocardial cushion defects, okay? And then the sinus venosus ASDs occur near the top of the atrial septum. Now, if we find a sinus venosus atrial septal defect, there's something you need to remember. What is it that you need to remember if you find a sinus venosus atrial septal defect?
Anomalous.
Yeah, almost all cases of sinus venosus ASDs are associated with partial anomalous pulmonary venous return. So you need to look carefully at all of the pulmonary veins to try to identify partial anomalous pulmonary venous return. Almost always, there will be partial anomalous pulmonary venous return if you identify a sinus venosus atrial septal defect. The patent for mental valley is really not a type of atrial septal defect itself, but we've covered that before, and the risk there is paroxysmal embolism. Now, secundums can also be associated with partial anomalous pulmonary venous return, but with sinus venosus, it's almost 100%. Again, large atrial septal defects result in equalization of pressure between the right and the left atrium. Why is there a left to right shunt? Lower right vascular resistance through the pulmonary circulation. So the blood follows the path of less resistance, and so you will have predominantly left to right shunting. If you have a large ostium primum and a large ostium secundum, that's called a common atrium, so it's like one big common chamber over there. So ASDs can produce high flow, low resistance shunts that can be well tolerated for years. So what's the implication of that? The implication of that is this is the most common left to right shunt that you might identify in an adult is an atrial septal defect, because these are usually well tolerated. Patients don't usually develop Eisenmengers, although they can. It is possible, but it's the most common of the left to right shunts that is found in the adults. This type of ASD through the middle of the atrial septum is secundum, right? That's the secundum. That's the most common. 15% association with partial anomalous pulmonary venous return. There's also an association with mitral valve prolapse. Low pressure shunt, well tolerated, most common left to right shunt in the adult. Development of Eisenmengers less common than with VSD or with PDA. The radiographic findings of ASD, we always start with, when you're dealing with the chest radiograph, you always start with pulmonary vascularity, so the pulmonary vascularity should be increased, of course. We're dealing with left to right shunt. What chambers are enlarged when you have atrial septal defect? Yeah, predominantly right-sided enlargement. The key is what is not enlarged? The left atrium, right? The left atrium is not enlarged. So that can help you, right? If you know you're dealing with a left to right shunt, but the left atrium is not enlarged, if you have right heart enlargement, right atrium, right ventricle, then we think atrial septal defect. Still might go to Eisenmengers as a complication in some patients, so that is still possible, okay? And over circulation, you need 2-to-1 shunt before you actually see the changes on the chest radiograph. We've talked about the chambers that are enlarged with atrial septal defects. Okay. The secundum, most common, right atrium, right ventricle, right heart enlargement there with atrial septal defect. On MRI, sometimes looking on the dark blood imaging can be tough because the signal, it's very thin, the atrial septum, the signal can drop out, so you want to make sure you identify it. If you think there's an ASD, you want to identify it in multiple views, multiple planes. Also, your bright blood imaging is going to be very helpful, of course, so you want to look at that and try to identify the defect on your bright blood imaging. Right? And so, right heart enlargement, there's the defect there on this MR. And then a nice, clever way to actually be able to demonstrate it is if you can apply saturation bands to the pulmonary veins, as they're coming in here to the left atrium. Then you saturate out that blood and you can actually see it going across the atrial septum. So it's a very cool way of demonstrating that. Okay. So next time you find one on the EMR table, try this. Okay, what is the path of this catheter? So it's coming down in what? SVC, and then it goes into, now what happens? How do you explain what's it doing over there?
This is the pulmonary vein.
How did it get to the pulmonary vein?
That's really a stage.
Yeah, so either an ASD or pain foraminal valley is also possible, but we're talking about ASDs. So across an ASD and then it can go out into the pulmonary vein. Okay, so that might explain the strange position of the catheter there if you have an atrial septal defect. Now, on angiography, when they're demonstrating these, if they need to, it helps to inject the pulmonary vein rather than inject the atrium itself, because preferentially the flow in the atrium is going to go right into the ventricle. But when you inject the pulmonary vein, then it tends to come down right along the atrial septum, and then you can see the flow nicely going across the ASD. So here's examples here showing you that pulmonary venous flow coming down, going across the atrial septum. Okay. What kind of ASD is that? Yeah, that's a primum ASD. It's located down low near the inlet portion there of the chambers, of the ventricular chambers, so that would be an inlet VSDs. These of course can be part of endocardial cushion defects. Okay, so here's an example of an ostium primum atrial septal defect. Again, the catheter goes across a PFO in this case, injecting a pulmonary vein. You can see the contrast come down and actually go across that inferior portion of the atrial septum through an ostium primum, through a primum atrial septal defect. Okay. All right, so we have various images here. What's the problem here when we look at this image? There's an obvious problem there, which is what?
Large pulmonary artery.
Yeah, that main pulmonary artery is really big. And here you can see that even the where the pulmonary valve is, that's also really big over there. Okay, and now when we look at the cardiac chambers, what chambers are enlarged? Right atrium and right ventricle are enlarged. What do you think of the thickness of the right ventricular wall there? It's very thick, right? So when you look at this image over here, do you see the problem?
Big shunt.
Where?
Atrial.
There's what kind of ASD is that? That's a sinus venosus ASD, which means what?
You have the upper
Anomalous pulmonary.
And
there is SVC,
do you see it?
top left image.
Top left image, right? You can see these vessels, these are pulmonary veins, and they're going into the SVC. I mean, someone described this as the seagull sign. Sometimes you can see it kind of looks like a seagull, I guess. But so very common to actually see pulmonary veins like that going into the superior vena cava when you have a sinus venosus ASD. So the point is, you find the sinus venosus atrial septal defect. Here it is, really up high. This guy over here is what? That's the junction of the SVC and the right atrium, right? So this defect is really high. It's up there near the junction of the SVC, so that makes it a sinus venosus atrial septal defect. And in here, we formatted 4 chamber view to show you how high it is there within the atrial septum. Okay? And then here, you can see, there it is up there, that upper portion of the atrial septum. So that's a big sinus venosus atrial septal defect. And then here was the contrast that's coming down. You can see the pulmonary veins here going into the superior vena cava. And then this is a short axis view. Here's the atrial septum. Here's the sinus venosus ASD. You can see the contrast coming down and actually falling through. This is called the fall in contrast sign. Remember, the contrast is denser than the blood, so it can actually follow gravity and fall into the left atrium like that. So that's a nice illustration of the fall in contrast sign there through a sinus venosus atrial septal defect. And then here's your partial anomalous pulmonary venous return going right into the superior vena cava. Okay? So sinus venosus ASDs, make sure that we look for partial anomalous pulmonary venous return whenever we come across those. They will be up high in the atrial septum near the insertion of the superior vena cava. Now, more examples on MR. There's the SVC, there's the defect. Start looking at all your pulmonary veins, and you might see some like this going into the superior vena cava, okay? Or even into the right atrium. So they can go into the SVC or the right atrium. So what kind of view is this?
Short axis.
That is a short axis, right? So what chamber am I showing you here? Nope, that's the left atrium. Just like you can do short axis views through the ventricles, you can do short axis views through the atrium. So this will be the left atrium, this will be the right atrium, this will be the interatrial septum. This guy down here is IVC, right? So you see the defect here, right? What kind of defect is this? Yeah, so this is that lower part, that lower, the inferior sinus venosus atrial septal defect. So this occurs near the insertion of the IVC. It's a rare type of ASD. It's associated with partial anomalous pulmonary venous connection of the right inferior pulmonary vein into the IVC sometimes. Okay, so defects down there can also occur near the insertion of the inferior vena cava. All right, what is this thing? Yes, so that's an Anplatzer closure device. So these are used to close vein foramen ovale or atrial septal defects. So these can also be used to close atrial septal defects. So notice it's an umbrella-like device. It grabs onto the lips of the ASD, and that's what holds it in place, right? As it grabs the lips of the ASD there, right? So it looks like this. So these rims are what grab the lips of the atrial septal defect. So they put it in place, and then it deploys, grabs the lips of the ASD, and that's what keeps it in place, and that occludes the ASD. So it's placed under fluoro and echocardiography there, so you can see transesophageal echo goes across there. They deploy it, closing the atrial septal defect. So here's your transesophageal echo probe, fluoro at the same time. You can see it going across, and it's starting to deploy, and when it opens up, grabs the ASD, the lips of the ASD, and closes it. Okay? And that's what it looks like on the plain film. This kind of umbrella-like device there over the atrial septal defect. So if you see that on the plain film, you'll know what that is. So ASD closure devices. Okay. Now sometimes before they place them, they need to have the ASD evaluated. So what you need to look at is to look at the lips of the atrial septal defect and make sure that they're sufficient, that there is enough tissue there for the closure device to grab onto. Here's a short axis view. You can see here that this part of the lip is deficient. It's missing there. So there's nothing there for it to grab onto. So the patient would not then be a candidate for this device. So we need to evaluate not only the atrial septal defect, but you need to evaluate the size, because then have to determine that you have the right size device to go across, and also you need to evaluate the lips of the atrial septal defect to make sure that there's enough for the device to hold on to. Okay. Does the phase of the cardiac cycle matter if you're measuring the size of an atrial septal defect? Is an ASD larger in systole or diastole? Which do you think? So we have a split decision here. Systole, diastole. So it's larger in systole, right? So in diastole, remember these valves are open, so the blood flow can decompress, can go down into the ventricles. So it's going to be, you want to make sure if you're measuring the size of the ASD, you want to make sure that you're measuring it in systole. Again, just illustrating the various rims, and you need to evaluate these rims to make sure that there's something for it to hold on to. There's a rim missing here. You can see near the aorta, so this patient would not be a candidate for the closure device. Okay, so here's for chamber reconstruction as we're going through the intraatrial septum. There are 4 lips to evaluate, the superior and inferior over there, posteriorly, and then the superior and inferior lips there, more anteriorly. So you evaluate all of those, and this one you can see has a deficiency of that lip. Okay. All right, so we've covered that. No rim deficiency, good candidate. There's enough lips to go around for the device to grab onto. Rim deficiency, not a good candidate. You can see the deficiency right there. No lip there, no rim to grab onto for the device. And then here's another example where you have a deficiency down here. Not good. And the problem is that this is what happens. If you try to put it in these patients, it becomes this large and starts floating around, or can actually embolize. So you don't, of course, you don't want that. Okay. Patient had placement of this metaport there, and blood returned from bright red. What happened?
Is it dislodged?
Well, where would it be then? Why is it bright red blood?
Could be in the aorta.
Could it be in the aorta? I mean, the tip's over here.
Oh,
Tip's over there. Right?
in a pulmonary vein?
So how would you explain that, getting into a pulmonary vein? How is that possible?
Yeah.
Partial anomalous pulmonary venous return connecting to what? SVC, right. So remember, this goes into the SVC. So if you have a pulmonary vein that connects to the SVC, right, then you might get a catheter going into the pulmonary vein. So that might explain some, unusual positions of catheter. Whenever you're not sure where a catheter is, first thing is check the blood return on the catheter, right? Make sure there is blood return so it's not sitting in the mediastinum where there's soft tissues. So this is going into a pulmonary vein with partial anomalous pulmonary venous return here, going to the superior vein cava. So that's what's happening in this particular case. Okay. So partial anomalous pulmonary venous connections, we've talked about the associations with atrial septal defects, but these can also occur as isolated anomalies without any atrial septal defects. We've emphasized the importance of the sinus venosus ASDs. Where do these veins connect? The pulmonary veins, SVC, it can connect to a bunch of places, SVC, coronary, sinus, subclavian vein, so any vein there. But the SVC is very common. And also the brachiocephalic vein, especially the left brachiocephalic vein, is a very common connection here. And this you will see quite a bit in clinical practice, where you have partial anomalous pulmonary venous return of the left superior pulmonary vein going to the SV, going to the left brachiocephalic vein. So you will see that. The findings, just like with an ASD, right-sided, these can give you a left to right shunt, right-sided chamber enlargement, right atrium, right ventricle. So partial anomalous pulmonary venous return gives you the same findings as an atrial septal defect. Okay, left to right shunt, enlarged right-sided chambers, and of course you can have big pulmonary arteries if there's enough left to right shunting. Okay, and it's hard to identify the abnormal vein and on the chest radiograph, of course, but you should be able to see it on CT. Sometimes, as we've discussed, these abnormal catheter positions or these catheter paths might be secondary to partial anomalous pulmonary venous return. Is another example. This one, of course, when you see this, you're going to freak out. Where is this thing going? It turns out it's going into a pulmonary vein. Fortunately for this patient, it's not sitting out there in the lung. Okay. So, interesting chest radiograph. A little bit of increased pulmonary blood flow there, but is there any other problem?
Scimitar sign,
Yeah, so what is the scimitar? What does that mean?
partial anomalous pulmonary venous
Of what?
of,
Of what? Anybody? Of the right lung, the entire right lung. So it's partial, so the scimitar vein, so this represents all of the pulmonary venous return from the right lung going to where? Going to the IVC, right? And that can give you that scimitar sign, scimitar vein. Right? This can be associated with other anomalies, not in this case, but also hypoplastic right lung or small right lung. So that scimitar vein really represents the venous return, usually of the whole right lung, draining to the inferior vena cava. And it can give you that abnormal dilated vein on the chest radiograph can look like a scimitar. Here's another example. See that scimitar vein here. This case does have a smaller right lung, so this is commonly associated with a small hypoplastic right lung. Other findings can be associated with sequestration, bronchial anomalies, accessory diaphragms. Interestingly, most of these patients will have an intact atrial septum. 95% have an intact atrial septum, so not a very strong relationship with atrial septal defect, so scimitar syndrome. Okay. Another example, small right lung, there's the vein, there's the scimitar vein. Okay. So if you see it, you might notice the small right lung, right? So if you notice a small right lung, something to look for. Look for that scimitar vein. All right. So there's an abnormal vessel illustrated here. Which image shows you? Do you see where the vessel is?
Very persistent.
So right here, this guy over here. Right? You shouldn't have a vessel like that sitting in front of the aorta. Right? So the question is, what is that? What is this vessel? It does connect to this, which is the brachiocephalic vein. Right? So there are two possibilities when you see a vessel like that sitting anterior to the aorta, connected to the brachiocephalic vein. What are the two possibilities?
Anomalous pulmonary vein.
Partial-
PAPR or duplicated SVC.
Yes, so a persistent left SVC or partial anomalous pulmonary venous return from the left upper lobe going to the brachiocephalic vein. Now, how do you differentiate them? How do you tell them apart on the CT? Where does it go, right? So if it's a persistent left SVC, it should go where? Down to the coronary sinus, right? It should go all the way down to the coronary sinus. Whereas if it's partial anomalous pulmonary venous return, it should connect to pulmonary veins, right? That's partial anomalous pulmonary venous return. What is this? Which is this? Yeah, it's connected. You can see the connection here to pulmonary vein here, so that helps. That makes it easy. Partial anomalous pulmonary venous return. And here, you don't see the vessel anymore. You don't see the abnormal vessel here. This guy here, what is this guy here? Well, this guy's easy. This guy is the pulmonary artery. What's this guy over here? That's the left atrial appendage. What vessel should be here? What vessel should be there? Which one? The left superior pulmonary vein. It should be there, but it's missing. There's nothing there, right? Because instead of going down to the left atrium, it is going up to the brachiocephalic vein, right? So this is partial anomalous pulmonary venous return, pulmonary vein. Okay, there it is, going up that way. Again, the first thing we want to look at on your ICU films is lines and tubes. What do we notice here?
That left central vascular catheter is not in the right place.
That's right, it's going straight down. So of course you want to check for blood return, and if there is blood return, what could explain the path of this catheter?
Anomalous left upper pulmonary venous return.
Yeah, but that you would, if it's in the upper lobes, right, you would expect the catheter to go out.
Be the left SVC.
Yeah, so this is going all the way down, right? So when it's going all the way down like that, what travels all the way down like that? A persistent left SVC. This is very common to have, a catheter that goes all the way down like that, so you have to think that maybe there's a persistent left SVC in this case. Right? What are the two vessels here, right? So here's your vessel. What do? We follow it up and down. You can follow it all the way down, and it drains to the coronary sinus. Right? Down here, remember when we had the partial anomalous pulmonary venous return, there were no vessels here. Now we have two vessels here. What are the two vessels? A and what's A? What's which is which? Which is A? Which is B? So we have one vote for A being the left superior pulmonary vein, and B being, B would be then the persistent left SVC, right? Well, your persistent left SVC is this guy, pulmonary vein. Okay? This is a great test question. Okay, so there's your persistent left SVC, comes all the way down, drains to the coronary sinus. Okay? And then here you can follow it. There it is. Follow it all the way down, 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 down. There it goes. Notice when it goes through it again, notice where it is relative to the left superior pulmonary vein. Okay? So there it is coming down. And then there's your left superior pulmonary vein that comes in behind it. Okay? All right, so we've talked about the persistent left SVC. So you want to make sure that you can tell them apart. You just follow it up and down. You should be able to tell it apart unless you get a nasty question like I gave you there earlier. Right? So partial anomalous pulmonary venous return. There's nothing anterior to the left upper lobe bronchus there. Persistent left SVC. You'll see two things, two vessels anterior to the bronchus. Okay? And we've kind of gone through all of this already. Okay, what's wrong here? Yeah, so first we have a common atrium. What's the problem here? Yeah, this is, what kind of VSD is that? Well, but it's near the inflow valve, right? There's nothing connecting it there. So this is an inlet VSD. Right? What is this thing? Remember, you should have, between the atrium and the ventricle, you should have, between the atrium and the ventricle. Valve. Right. There should be two separate valves. This is one large common bridging valve between the atria and the ventricles. What is this disorder? Anybody?
AVSD.
It's a complete endocardial cushion defect, right? This is a complete endocardial cushion defect. In the complete form, you have one common bridging valve here going across big ASD, big VSD, right? So a real problem with the endocardial cushions. So they contribute to this portion, the formation here, the separation there, right in the center of the heart, okay? So you can have ASDs, VSDs, and in the complete form, you can have one common bridging valve going all the way across. Right? So those are your atrioventricular septal defects. They can be partial, they can be complete. I mean, I'm not going to test you on the intricacies and the differences of those. Just realize that these are, the complete form is associated with Downs, with trisomy 21. Make sure you can recognize the complete form. That's usually the form that you might be shown on exams. Recognize the complete form of endocardial cushion defect. So with the complete form, you will have ASD, VSD, but you will have one common bridging valve going all the way across here. And that's your complete endocardial cushion defect. And that's associated with trisomy 21, the complete endocardial cushion defect. Partial defects, because of the problems with the valve, can be associated with mitral regurg. Again, that gets out into the weeds, but just be able to recognize the complete endocardial cushion defect. All right. So with those defects, with the complete defects, there's marked pulmonary overcirculation. Patients can develop CHF or Eisenmenger's, bony anomalies, of course, also associated with trisomy 21. Sometimes because of communication of all four chambers, you can actually get an admixture lesion where they might also have cyanosis with bidirectional shunting instead of just left to right shunting with these. So big pulmonary overcirculation, right? So you will expect to see that with these endocardial cushion defects. The partial defects will resemble more ASDs, milder left to right shunts with partial defects. And another bit of trivia with these endocardial cushion defects, there's something called the gooseneck deformity because there's a deformity in the outflow tract of the left ventricle. Okay, so you get this elongation of the outflow tract, looks like a gooseneck. That's called a gooseneck deformity, in addition to mitral regurgitation. So gooseneck deformity is also associated with endocardial cushion defects. All right, be able to recognize that on imaging. You have that one common bridging valve going all the way across, okay? Or a big hole right in the center where all four chambers communicate right in the center of the heart. That's also a complete endocardial cushion defect. There's an illustration of the gooseneck deformity there. Okay? Here's another nice example of a complete endocardial cushion defect, one common bridging valve. That in this case, there's a giant hole right in the center of the heart, allowing communication of all four chambers. Okay. Another bit of trivia, this case demonstrates an abnormal communication between what two chambers?
Left ventricle and right atrium.
Yes, and there is a term for this. So right here, this portion of the septum, if you put a hole, because the tricuspid valve is displaced slightly more towards the apex of the ventricle than the mitral valve, that's normal, right? Because of that, this portion of the septum, if you put a hole there, you get direct communication between the left ventricle and the right atrium. There is a term for the defect that occurs right there. What is that term? That is Gerbeau defect, right? That is called a Gerbeau defect. If you have a hole in that portion of the interventricular septum, that allows direct communication between the left ventricle and the right atrium. You get a big right atrium and also a left to right shunt. That is called a Gerbeau defect. Okay. The obvious problem here is big pulmonary artery, and your answer is on the second image. What's the cause? And you can see it, right? So you can see the communication between the aorta and the pulmonary artery. PDA is commonly calcified, and especially in adults, right? So you can see calcification of the patent ductus arteriosus. And here's a reformatted view showing a huge pulmonary artery, big aorta, big patent ductus, and there is the calcified ductus arteriosus there in that case, right? So these, of course, give you left to right shunts, communication there between the proximal descending thoracic aorta and the pulmonary artery. Most commonly occur in preemies, high flow, high pressure shunts. If there's a lot of, this can result commonly in Eisenmangers, the PDA, because these are high flow, high pressure shunts. Okay. MR, you can see the jet right there, the communication between the undersurface of the aorta going right into the pulmonary artery. Cardiomegaly proportional to the severity over circulation, and if cardiomegaly decreases, consider Eisenmangers. Can also be associated with infective endocarditis. Okay? Pulmonary overcirculation, big pulmonary arteries here, okay? And PDAs can result in Eisenmangers. This was an adult patient who had Eisenmangers because of the PDA. What finding on the chest x-ray tells you that this is a PDA? We have overcirculation, big pulmonary arteries. If you're thinking left to right shunt, adult patient, what is the finding on the chest radiograph that nails it? That's a PDA. What's the finding?
The calcification between the aorta and
Yes. The calcification here in the AP window, right? That is the calcification of the ductus arteriosus, okay? So calcification, it's common for these to calcify in the adults. Calcification, remember, we get calcification of the ligamentum arteriosum, right? That's a thin calcification, that's normal. That indicates a closed, right? But if you have overcirculation and you see calcification there on the plain film, then we are thinking of patent ductus arteriosus, right, in the adult patient. There it is on MR, very easy to demonstrate there on MR with the PDAs, okay? Pretty easy to demonstrate on imaging. Here we saw this example, very easy to show. And it's common again for adults to have calcification. of PDAs. So look carefully at that if you notice that. All right? Treatment closed with these embolizing devices, with these coils that can be put in there, especially in children. Put that in there to close the PDA. Looks like a little bit of a star sometimes. Okay, here it is. There it is there. There's that little star. That's a PDA occlusion device. Oh my goodness. What's the problem here?
There's a,
So what is this guy? Here, let's play the movie for you, make it even more fun. So this guy over here, well, this guy here is easy. What's that guy? That's the aorta, right? That's the aorta. What is this guy? That is the main pulmonary artery, right? So we have direct communication between the ascending aorta and the pulmonary artery, right? Very rare form of left to right shunt, physiologically like a huge PDA. What is this called? What's the term for this?
aorticopulmonary window.
Yeah, so that's an aortopulmonary window, right? So that's direct communication between the ascending aorta and the pulmonary artery. So that's called an aorticopulmonary window, also called aortopulmonary septal defect, rare defect, deficient septation of the truncus arteriosus, large communication. Now, how do you differentiate this from truncus arteriosus? Both valves are present, right? So the aortic valve is there, the pulmonic valve is there. With truncus arteriosus, you only have one outflow valve. Here you have both outflow valves, but there's direct communication between the aorta and the pulmonary artery. That's an aortopulmonary. And this patient walked into our ER and lied down on our CT scanner, this one right here. Yes, yes. So, I mean, these are rare, right? Why is it important to know? Because you may only have one chance in your life to get it right. Okay? So, same as large PDA, pulmonary overcirculation there, big vessels, the same chambers will be enlarged. The difference is the communication is going to be between the ascending aorta and the pulmonary artery, right? With this aortical pulmonary windows. Nice black blood imaging here to show you that communication between those guys there. Okay, chambers enlarged. Make sure you know this. We've kind of covered all of these guys. Okay, so partial AVSD, like ASD, complete AVSD, more like a VSD. Okay. All right, we start with the pulmonary circulation. It is increased, decreased, or normal? Increased, right. The question you ask, patient, right. Patient is not cyanotic, right. Now we can look at the heart and the chambers. The chamber that you want to clue in on is left atrium. What do you think? You think it's big or not?
Left atrium is pretty big.
You think it's big? So what could this be then? Right-sided chambers are big too, right? What's the answer? VSD, right? So with VSD, you do get left atrial enlargement, okay? All right. Increased pulmonary blood flow?
Yes.
Yes. Patient is not cyanotic. We're in the category of shunts. Possibilities are, your three choices are
ASD, VSD.
ASD, VSD, PDA. Right? Do we think the left atrium is enlarged?
No.
You don't think the left atrium is enlarged? Do we have a no? You think the ascending aorta is enlarged? Well, if the ascending aorta is enlarged, what does that mean? Which one would it be? Which of those gives you a big ascending aorta?
PDA.
And the answer is
PDA.
PDA, right. Of course, remember, the flow goes from the aorta through the PDA, right? So the ascending aorta will be enlarged also with a PDA. Okay? All right, increased pulmonary blood flow. Patient is not cyanotic. Do we think the left atrium is enlarged?
No.
No. So we're down to,
ASD.
and the answer, of course, is ASD, right-sided chamber enlargement. Patient has an atrial septal defect. Okay? Any ideas?
Is the gooseneck,
Gooseneck deformity, right. So what will the answer be?
or
Well,
atrial?
you remembered the gooseneck, but now you got to remember it is a complete endocardial cushion defect. Okay? All right. So that is our discussion of Shunts. Quiz next time. Any questions? Okay.
Thank you.